Prolactinomas. Prolactinomas are the commonest functioning pituitary tumor. During life, microprolactinomas are commoner than macroprolactinoma. The pathogenesis is unknown. It occurs in 20% of the patients with MEN1. Prolactinomas are the commonest pituitary tumor in MEN1 and may be more aggressive than sporadic prolactinomas. Malignant prolactinomas are very rare and may be associated with RAS mutation. Hyperprolactinomas, both microadenomas and macroadenomas, can lead to galactorrhea in up to 90% females and less than 10% in males. There is disturbed gonadal function in female who may present with menstrual disturbance in up to 95%. Otherwise, they may present with amenorrhea, oligomenorrhea, with fertility and infertility and reduced libido. There is disturbed gonadal function in male who presents with loss of libido and erectile dysfunction. Presentation with reduced fertility, oligospermia, gynecomastia is also typical presentation. Hyperprolactinemia is associated with long-term risk of decreased bone mineral density. Hyperprolactinemia inhibits GnRH release, leading to decreased LH secretion. There may be direct action of prolactin on the ovary to interfere with the LH and FSH signaling, which inhibits estradiol and progesterone secretion and also follicle maturation. Macroadenomas can lead to mass effects, which then present with headache and visual field defects, hypopituitarism, invasion of the cavernous sinus, and occasionally CSF leak. So the causes of hyperprolactinoma include physiological, pituitary tumor, hypothalamic disease, infiltration, stalk section, cranial irradiation, drug treatment, metabolic, and idiopathic. So among the physiological causes, the causes are basically nipple stimulation and suckling, sexual intercourse, pregnancy, neonatal periods, and stress. Among the pituitary tumor, prolactinomas, mixed growth hormone and prolactin secreting tumor, macroadenoma causing the compressive stalk, empty cellular syndrome. Among the hypothalamic disease, causing a mass effect can lead to stalk compression. The typical tumors are craniopharyngioma, meningioma, and neurofibromatosis. Among the infiltrative disease, sarcoidosis, Langerhans histiocytosis are the common ones. Stalk section, because of the head injury or surgery, can also lead to hyperprolactinemia. Furthermore, drug treatment includes dopamine receptor antagonist, including metoclopramide and domperidone, neuroleptics, including fluphenazine, haloperidol, chlorpromazine, and risperidone and sulpiride. Among the antidepressant, DCAs, SSRIs, MAO inhibitors, sulpiride, imipramine, clomipramine, amitriptyline. Among the cardiovascular drugs, verapamil, methyl dopa, and reserpine can be a confounding factor. Opioids and cocaine can also lead to hyperprolactinemia. And furthermore, estrogens and protease inhibitors can lead to raised levels of prolactin. And among others, omeprazole and H2 antagonists can also lead to increased level of prolactin. Among the metabolic conditions, hypothyroidism may cause hyperprolactinemia by increasing the TRH release. Chronic renal failure may lead to increased prolactinemia because of the decreased prolactin clearance. Among the liver disease, severe liver disease can also lead to prolactinoma because of the disordered hypothalamic regulation. PCO and chest wall lesions can also lead to hyperprolactinemia. So the investigation of prolactinoma is very important. That serum prolactin less than 200 milliunit per liter suggestive of tumor, either a microprolactinoma, a non-functioning macroadenoma compressing the pituitary stalk with loss of dopamine inhibitory tone to the electrotrough and subsequent hyperprolactinemia. Serum prolactin greater than 4,000 milliunit per liter is diagnostic of macroprolactinoma. Hook effect. This occurs where The assay utilizes antibodies recognizing two ends of the molecule. One end of the molecule is used to capture the molecule. One end of the antibody is used to capture the molecule and the one to label it. If prolactin levels are very high, it may be bound. It may be bound by one antibody, but not the other. Thus, above a certain concentration, the signal will reduce rather than increase, and very high prolactin levels will sporadically reported as normal or only slightly raised. Hypothyroidism and chronic renal failure should also be ruled out in case of hyperprolactinemia. MRI may reveal microadenomas, which usually appear as hypointense lesion. Microadenomas are space-occupied tumors, often associated with bony erosion and cavernous sinus invasion. Macroprolactin or brick prolactin, usually these are the aggregate forms of prolactin which are detected in circulation. These are measurable in the prolactin assay. They do not interfere with the reproductive function, but may be found in 10% of the patients referred. There is hyperprolactinemia with regular ovulatory menstrual cycles. Assays for the macroprolactin are available using the PEC precipitation with low recovery of prolactin demonstrates the presence of macroprolactin or gel filtration chromatography, which is the gold standard. Antipsychotic agents are most likely psychotropic agents to cause the hyperprolactinemia. If dose reduction is not possible or not effective, then NMRI to exclude prolactinoma and treatment of the hypogonadism may be indicated. When dopamine antagonism is the mechanism of action of the drug, then dopamine agonist may reduce the efficacy. Drug-induced increases are usually less than 3000 milliunit per liter. When no cause is found following evaluation, the prolactinemia is designated idiopathic, but in many cases, it's likely due to tiny microprolactinoma, which is not demonstrable on the current imaging. Follow-up of these patients shows that in one-third, prolactin levels return to normal. In up to 15%, there is further increase in prolactin, and the remainder prolactin levels remain stable. So the treatment aim of therapy is in microprolactinoma, there should be restoration of the gonadal function, and in macroprolactinoma, the aim is to reduce the tumor size and prevention of the tumor expansion. Restoration of the gonadal function is another goal. Although microprolactinoma may expand in size without treatment, the vast majority do not increase. Therefore, although restoration of the gonadal function is usually achieved by lowering the prolactin levels, ensuring adequate sex hormone replacement is an alternative if the tumor is monitored in size. Among the drug therapy, dopamine agonists are commonly used. Dopamine agonist treatment leads to suppression of the prolactin in most patients with secondary effects of normalization of gonadal function and termination of galacturia. Tumor shrinkage occurs at a variable rate, typically between 24 hours to up to 12 months, and the extent must be carefully monitored. Continuous shrinkage may occur for years. Slow occasional decompression will correct the visual field defect in majority of the patients, and immediate surgical decompression is often not necessary. Lack of improvement of the visual fields despite tumor shrinkage makes improvement with surgery unlikely. Restoration of the other hormonal axis may occur with tumor shrinkage. Cabergoline is more effective in normalization of the prolactin in microprolactinoma compared with bromocriptine, with fewer side effects than bromocriptine. Although cabergoline in higher doses used for the Parkinson can cause right-sided cardiac fibrosis, there is no evidence for this using the lower doses necessary for the control of prolactin levels. Dopamine agonist resistance may occur when there are reduced number of D2 receptors. Tumor enlargement allowing initial shrinkage. Following the initial shrinkage on treatment is usually due to non-compliance. A rare possibility, however, is a carcinoma. So tumor enlargement could be because of the non-compliance and carcinoma. Drug therapy, estrogen replacement rather than dopamine agonist therapy. may be appropriate in female with idiopathic hyperprolactinemia or proteinemias, where fertility and galacturia are not issues. Small short-time series suggest no evidence of tumor enlargement. However, individual cases where tumor enlargement has occurred make monitoring of the protein important. Since the introduction of dopamine agonist treatment, transplant surgery is indicated only for patients who are resistant to or intolerant of the dopamine agonist treatment. The cure rate of the macroprolactinomas treated with surgery is poor, and therefore drug treatment is first line in all tumors or tumor of all sizes. Surgery may be required for the CSF leak secondary to invasive macroprolactinoma. Cure rate for microprolactinomas treated with surgery are greater than 85%, but the risk of hypopit and recurrence makes this a second line option. Bromocriptine given for more than a month may make the tumor fibrous. The surgical management of CSF leak can be very difficult in patients with invasive tumors. Tumor shrinkage with dopamine agonist will either precipitate or worsen the leak with the subsequent risk of meningitis. There is no evidence for the long-term use of prophylactic antibiotics in this group, but patient at risk should be informed of the warning symptoms and advised to seek medical attention urgently. Standard pituitary radiation leads to a slow reduction over years of the prolactin in the majority of the patients. While waiting for the radiotherapy to be effective, dopamine agonist therapy is continued, but should be withdrawn on biannual basis to assess if it is still required. Cabergoline and valvulopathy. Cabergoline, but not bromocriptine, is 5-hydroxytryptamine 2B receptor agonist. High doses of cabergoline, that is 3 mg per day for 3 months, for greater than 6 months in Parkinson patient have been associated with valvular heart disease, that's aortic mitral tricuspid regurgitation, through the 5H2B target effect. The risk of cardiac valvulopathy appears to be low in prolactinoma patients on the standard dose of cabergoline, which is less than 2 mg per week. For patients requiring high cabergoline doses, annual clinical cardiac examination are warranted, and consideration should be given to periodic echocardiograms. Dopamine agonist resistance. It is defined as the failure to normalize prolactin, failure to decrease the size to less than 50%. It occurs in 25% treated with 25% of the patients treated with bromocriptine, 13% with pergolide, and 11% with cabergoline. D2 receptors are reduced in number but not efficacy. Treatment options include switching the dopamine agonist, increasing dose of dopamine agonist, or surgery, fertility treatment, or estrogen replacement. So, radiotherapy is not indicated in the management of patients with microprolactinomas. It is useful in the treatment of macroprolactinomas once the tumor has been shrunken away from the chiasm, only if the tumor is resistant. The natural history of microprolactinoma is difficult to assess. However, they are a common post-mortem incident finding, and less than 7% show any increase in tumor size. It has been demonstrated that hyperprolactinoma is approximately in 1/3 of the female will resolve, particularly after menopause or pregnancy. This shows that patients receiving dopamine agonist treatment for microprolactinoma should have treatment withdrawn intermittently to assess the continued requirement for it, and certainly the dose may be titrated downwards over the time. There are few data on dopamine agonist withdrawal in macroprolactinoma in the absence of definitive treatment, radiotherapy or surgery. There are data suggesting that cautious attempts at dose reduction could be considered after 5 years if the prolactin is normal and MRI shows no tumor. But it seems that the majority have recurrence of hyperprolactinoma, but to levels lower than pre-treatment levels. So dopamine resistance of prolactinoma, so failure to normalize prolactin and dopamine agonist therapy Failure to decrease the tumor size by 50% or more. The frequency is 24 with bromocriptine, 13 with pergolide, and 11 with cabergoline. The cause is D2 receptors on the tumor decrease in number but normal affinity. Treatment options are switch dopamine agonist, increased dose of dopamine agonist, transprenasal surgery, clomiphene, gonadotropins for fertility, and estrogen replacement therapy.